All right, today we're diving into something that's rare but absolutely critical for anyone working with dialysis patients. We're talking about dialysis disequilibrium syndrome, or DDS. It can be a really devastating neurologic issue, so understanding how to spot it, prevent it, and treat it is just essential.
So let's just jump right into a classic clinical scenario. Picture this, you get a call to the dialysis unit. Your patient just wrapped up their first ever run, and now they've got a headache and seem kind of off, confused. Your mind starts racing, right? Could this be DDS? This is the exact situation we're going to break down.
So what exactly is dialysis disequilibrium syndrome? Well, at its heart, it's a whole range of neurologic symptoms, and they're all caused by cerebral edema, that's swelling in the brain. It usually happens when dialysis yanks solutes out of the blood way too fast, which is why it's a huge concern for patients who are either brand new to treatment or maybe have missed a few sessions.
To really get a handle on this, here's our game plan for this explainer. We're going to start by recognizing DDS as the neurological emergency it is, and then we'll get into why the brain swells. From there, we'll talk about how to spot at-risk patients, how to make the diagnosis, and, super important, how to treat and prevent it. And we'll wrap it all up with a clinical cheat sheet you can take with you.
Okay, first things first. Recognizing the signs of DDS. It's so important to know what you're looking for because the symptoms, well, they can range from something super subtle to something truly life-threatening.
The main thing to see here is the spectrum. DDS often kicks off with something mild and pretty nonspecific, like a headache or feeling nauseous. But, and this is the scary part, that can quickly progress to confusion and sleepiness. And in the absolute worst cases, seizures, coma, or even death. This is exactly why you have to have a high index of suspicion, even for those mild symptoms, if the whole clinical picture fits. So, we know the symptoms, but why does the brain actually swell? Let's dig into the pathophysiology for a minute to really understand the mechanism here. The leading theory is something called the reverse osmotic shift. It pretty much works like this. Before dialysis, a patient's entire body, including their brain, is just loaded with urea. Now, hemodialysis is incredibly good at clearing urea from the blood, but the brain is much slower to let go of its urea. This creates this temporary osmotic gradient, where the brain is way more concentrated than the blood. And because water always follows solutes, it gets pulled from the bloodstream right into the brain cells, causing them to swell up.
And hey, this isn't just a theory, it's backed up by some classic experiments. Researchers found that uremic rats only developed brain swelling when they were dialyzed against a solution that had no urea. But when they were dialyzed against a solution that matched the urea concentration, the swelling just didn't happen. This was really the foundational evidence that pointed a finger directly at rapid urea removal as the culprit.
Okay, now for the really practical stuff. Knowing the why is great, but we really need to know who. Who are the patients you need to be watching like a hawk? Look, if there is one number to burn into your memory from this whole explainer, it is this one. A pre-dialysis BUN over 175 is a massive red flag for DDS. It tells you there's a huge urea load and the potential for a gigantic osmotic shift as soon as that dialysis machine turns on. Seeing this number should immediately make you think about prevention.
And beyond a high BUN, there are several other things that really raise the risk. The number one risk factor is the very first hemodialysis treatment, period. But you also have to be super vigilant with patients at the extremes of age, so the very young and the elderly, as well as patients with a history of stroke or seizures, and anyone with a condition like sepsis that might make their blood-brain barrier a little, well, leakier. All of these things can create the perfect storm for DDS.
Okay, so you suspect DDS. Now what? Let's walk through what your diagnostic approach should look like right there at the bedside.
And this is a really crucial point. There is no magic test or scan that's going to scream DDS at you. It is a clinical diagnosis of exclusion. That means your job is to suspect DDS based on the timing and the symptoms, while at the same time, you're actively ruling out other dangerous things like a stroke, hypoglycemia, or an infection.
So your approach is really going to depend on the severity. For milder symptoms, like a little bit of confusion, you're going to start with the basics, right? Review their meds, do a good physical exam, check a fingerstick glucose and their electrolytes. But if your patient has a seizure or is getting comatose, you have to escalate and fast. This means doing all those basic checks, plus considering neuroimaging to rule out a bleed or a stroke, and working them up for a possible infection.
All right, now for what I think is the most important part. What can we actually do about it? Let's cover how to manage an active case of DDS and, even better, how to stop it from ever happening in the first place.
Now, this might sound a little counterintuitive, but if you suspect DDS during a treatment, the preferred move is often not to stop dialysis. Instead, the goal is to start something called sodium modeling. This basically tells the dialysis machine to crank up the sodium concentration of the dialysate, which then raises the blood's osmolality and fights back against that water shift into the brain. It's pretty amazing. It can actually reverse symptoms in as little as 30 minutes. The alternative, of course, is to just stop the session, especially if the patient is going downhill fast.
So what if you've already stopped dialysis, but the patient's severe symptoms like stupor or seizures are sticking around? You gotta act fast. This is your moment to give IV hypertonic saline or mannitol. Both of these are powerful osmotic agents that will literally pull water out of the brain, directly treating the cerebral edema. You can think of this as your emergency rescue therapy.
Of course, prevention is always better than treatment, and your strategy really depends on the patient. For someone who's brand new to dialysis, the mantra is go low and slow. You start with shorter, less intense sessions and just gradually ramp up. But for a patient who's been non-adherent and comes in with a crazy high BUN, you might not have that luxury. For them, using sodium modeling right from the get-go is the key to blunting that massive osmotic shift.
Phew, we have covered a lot. So let's boil it all down to the absolute must-know essentials that you need to remember on your next shift. This is your clinical cheat sheet.
First up, always suspect DDS. If you have a patient who is new to dialysis or has missed treatments and they develop any neurologic symptom, I mean anything from a simple headache to confusing, DDS has to be on your differential diagnosis. Second, prevent it. For any patient starting hemodialysis for the very first time, especially if they have a high BUN, your initial prescription needs to be gentle. Shorter time, lower blood flows. Just remember, go low and slow. It's the safest way to go.
And third, know how to treat it. If symptoms do develop, your go-to move should be to start sodium modeling and try to continue the dialysis session. Believe it or not, this is often the fastest way to get the problem to resolve.
And we'll end with this thought. DDS is rare? Yeah, but it is largely preventable if you have the right knowledge and a little bit of foresight. So the question to take with you is this. Based on what we've just talked about, what's one specific change you'll make to your very next dialysis order for a patient you identify as high risk? Thinking through that right now is what's going to make all the difference at the bedside.